All right, if they should become positive, immediately take them off. You're going to do a resistance testing and then refer them either to treatment or treat them yourselves. Remember, if they do have chronic Hep B, that they may have a flare. I really haven't seen it. And then if they should develop renal disease, if that serum creatinine goes up a little bit, like from 1.1 to 1.2, hydrate. Are you doing creatine supplements? Stop that, repeat. All right. If it goes from 1.2 to 2, back off and see if there's some other issue that's going off, and then you're going to interrupt. All right. So there have been some reports of patients diverting the Truvada, so they're selling it. It's difficult to check for that because they're already negative. How are you going to know? Their viral loads are going to be, their HIV tests are going to be negative. Their viral loads are going to be negative, right? If you should screen. I don't think that's too big of an issue, but it's something that has been brought up. And then if they should change their behavior to where they no longer need it. Again, with like that serodiscordant, if they do want to stop, you want for them to continue that PrEP for 1 month after their last exposure. And that's how you safely discontinue PrEP. All right, you think you guys can do it? It's not that hard. Okay, so the last 10 minutes here, we're just going to go into the implementation. You do need to establish a plan in your clinic. You need a cheerleader, okay? You need to discuss it agency-wide, between and within the disciplines, ensure buy-in, address discontent and disagreement early on, refer to your mission, your public health focus, shared goals, and then you want to clearly develop a protocol. We have one which we can share. If you can embed it into your electronic medical record, that'll be easier for the care team. You want flexibility, test and change and see if there's any updates that need to be. And it does help if you have an appointed point person to troubleshoot implementation issues. All right? You do need that additional time spent on onboarding patients. Talk to patients about the pros and cons, discuss ambivalence, inform on insurance, guide through the process, and where available, have your care team, social worker, case managers, HIV counselors, peers, and then mental health and substance use referrals when you need them. And then internal or external agency collaborations as an alternative. Medicaid covers it. Commercial employer plans cover it. The Obamacare market share plans cover it, but maybe they have a deductible or a high copay. So those factors will really factor into the affordability of it. Medicare covers it. And for the uninsured, there are some programs, and these are some of them. So there are medication copay programs. So a pharmaceutical company can cover up to $300 per fill, max of $3,600 per year. If it's still high, there are other copay assistance programs. There's the Patient Assistance Network. And then if copay is still prohibitive, you may want to consider and counsel patients on alternative insurance plans. And then there are the pharmaceutical medication assistance programs. This is an example of one. So it will assist uninsured medication caps. There are no medication caps. There's no prescription coverages. So again, but you need this kind of in place before you start it. It's not impossible. It just takes a couple of runs, but you do need some staff to assist you with this if you really do plan on amping this up. You need to educate your staff about HIV infection. So it should be integrated into your PrEP and also your PEP, your post-exposure. They need to know the familiarity for how HIV transmitted, right? It's not transmitted in saliva, right? So that you can, smartly speak with patients about risk. Importantly, understand that role of acute HIV infection and how you may have undiagnosed with the standard diagnostic tests, which are antibody. Remember, even a rapid point of care test, what it's detecting is just antibodies. So it's not going to detect early infection. Educate them on the difference between post-exposure prophylaxis versus pre-exposure prophylaxis. And we do want to enhance partners' understanding of safer sex. What's really important too is who are you having sex with? What's their status? If they're positive, are they on antivirals? What's their viral load? All of that discussion really has to go into this kind of matrix of like explaining risk. And then reduction of HIV stigma. So you do want to manage patients' expectations immediately the timeline for access. They're not going to get that pill the first day, right? They're going to have to do these baseline tests. We got to make sure that their insurance is going to cover the medications. But you want to review this with the patients and have them understand all of these steps. How about the availability of providers? So how about your access for new patients? How about for employed patients that may need weekend or after hours? And what's your process for accessing medication refills, right? So if a patient, let's say it's been over 3 months and they say, hey, I just can't get in to see you, but I ran out of my medications. How are you going to address that issue? You got to balance access with what if they seroconverted? Are we going to want them to continue just on Truvada? So those systems have to be in place for getting patients in and for checking their HIV status before you can continue with refills. And remember to educate patients about that tail. So if you should stop, that after about 3 days, those drug levels are going to drop and you may not have the same protection. So therefore, the importance of other prevention strategies like condoms. And then there's PrEP stigma. Patients have their own stigma about PrEP. They have fear of side effects, short and long term, and those are not well founded. And remember that, balance it with like, wow, what if you should become HIV positive? What does that mean? It's a lot more medications, a lot more visits, a lot more toxicities. There's a fear and dislike of taking medications, and there's this fear of peer judgment. How does that label me? I do think that that's changing. And then addressing these self-stigmatizing beliefs. And I'll just give you one little anecdote very quickly. So we had a patient that was engaged in high-risk sex at a bathhouse in New York. He came in for post-exposure prophylaxis, all right? So remember, that's the month-long therapy after an exposure. So we put him on PEP, which was at that time Truvada and Icentris, okay? So that's what you do for PEP. It's a fully suppressive regimen. Give it within 72 hours. They take it for a month. And he had been engaging in a lot of unsafe sex, multiple sexual partners, receptive anal, drug use, and things like that. So we started him on PEP. He was adhering to the medications. I saw him in 2 weeks. I started to introduce that topic of PrEP. And when I started to talk to him about PrEP, what he said, I said, do you think that you're ready to start on PrEP? And he said, well, I don't think I want to start on PrEP because I think it's going to make me, quote, unquote, sluttier. And I was like, how much sluttier can you get? You know, I mean, it's like, but again, his own stigma about what this medication. So anyway, I said, I'm going to stick with him after PEP. I'm really going to try to onboard him and have more of the conversation with him. So he finished his PEP. We did testing. He was HIV negative. I said, hey, I'm going to give you this information again. Come back in 2 months. And when I saw him in 2 months, I was very excited to see him because I knew that, hey, maybe we can start. So I said, hey, are you ready to start on PrEP? And he showed me his HIV positive result. You know, what a missed opportunity there. So that's what really sticks in my mind about why I think this prevention strategy can be very effective. And we got to get those groups that are most ambivalent. All right, so you do want to bring community into the conversation. So, you know, you have to talk about their patients' relationships. Are they in a relationship? Is it open, closed? All of those issues, which I find very interesting. And not all doctors do that. I like it that I went to my doctor for the first time because I don't see doctors, right? I'm a physician. I'm an internist, but I finally went, which is great. And, you know, he didn't offer me an HIV test at all, you know. And I was like, okay, you know, I was like, hey, what? Why don't you just go ahead and do it? But it's just funny, even in like New York. So again, you know, routinizing HIV testing and having these open conversations, patients will appreciate it. And if the partner is positive, make sure they're on therapy, their viral loads are undetectable. Data shows that undetectable patients, their likelihood of transmitting is very low. There's even data in cohorts to show that the point estimate was 0. So that's treatment as prevention. You know, diagnose early, everybody. Now data supports, even if their T cells are 1,000, you offer them treatment because there's an individual benefit. And if they're on treatment, viral loads, undetectable, they don't really transmit. And, you know, for the partners, is PrEP being considered? I had this one couple, heterosexual, he's HIV positive, she's HIV negative. She wanted to come in to start on PrEP. They do use condoms for like penetrative sex, but they wanted to decrease the anxiety about kind of intermediate risk things, so like oral sex, or if there was cervical vaginal, if she was menstruating, or ejaculant. So she actually said, and they actually said that it made their sex more intimate because it took away that fear and risk of HIV. So I will end there. I know it's a bit of a whirlwind, but I just wanted to give you guys this kind of how-to, because the science is not tough, you know? And the onboarding is not. It's that implementation. It's that change in the thought about how we're going to address prevention. You know, condoms are great, but they're just not consistently used. The other thing is that for partners or for women especially, they can take prevention into their own hands. They don't have to demand that the male wears a condom, that it stays on. You know what I mean? She or he can take prevention into their own hands. So it is very empowering. And chemoprophylaxis does work. So now it's really part of an evidence-based menu. And although the overall number of new HIV infections is decreasing in the U.S., there are subpopulations, we spoke about them, but especially young MSM, where it really continues to be a driver. And it does complicate life, and it does affect health and the quality of life. So PrEP may be an effective option to augment behavior change in these high-risk populations. So just special thanks here, and then I guess I'll open it up for questions. Two questions.